Welcome to a Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about global health and human rights. This is a series brought to you in partnership with the Bay Area Global Health Alliance, a group of companies, both biotech and tech, as well as other sectors, academic institutions and non-profits, all committed to improving the lives of people around the world. You can find out more about them through their website, which is www.bayareaglobalhealth.org. Well, in this episode, we are going to meet again Professor Peter Piot, who is the Executive Director of the London School of Hygiene and Tropical Medicine. He is one of the leaders in the global fight against AIDS, and more recently, he's been in the press as a survivor of COVID-19. And he's testament to the fact that the recovery process for COVID-19 can be a long and arduous thing, not something that magically disappears. Anyway, Peter joins us from his home in London as both he and I prepare for the virtual AIDS 2020 and virtual HIV 2020 conferences about to kick off. Peter, welcome to a Shot in the Arm podcast.
Good to see you, Ben.
Even though it's thousands and thousands of miles, who could believe that just over a year ago, we were at the Commonwealth Club with Professor Larson talking precisely about this, how to prepare for future pandemics. Would you have imagined that this is what it would be like just a year later?
Well, the irony is that for at least 5 years, I've been going around the world giving a talk with as a title, "Are we ready for the next pandemic?" And the conclusion was, no, that was the answer. So I was convinced that this would happen, but I was wrong on two fronts. One, I thought it would be a variant of influenza virus, so some kind of new flu. And it's a coronavirus. Okay, that's a technical detail, because it was going to be a respiratory virus. And secondly, I think I had underestimated the enormous societal devastation that it would bring beyond the public health part. That's, because that's unprecedented, what we're seeing, at least in modern times. We've seen that with the plague in the Middle Ages and later on and other epidemics, but in modern times. So that is something I hadn't thought through. But yes, I mean, and I was not the only one. Anybody dealing with epidemics had said, one day we will have this. And this may not be the big one. This could be a rehearsal for something with a much higher mortality. I mean, it is very contagious, and that's still something that is not appreciated, but it suffices to look at the figures, and we know that it is spreading like wildfire.
Oh yes, and certainly over here at the moment, we aren't through our first peak, but our first spike. But this has affected you very personally as well, and it's been intriguing, perhaps not surprising, given your heritage in the fight against AIDS, that you've been very open. You've come out about being infected and living with COVID, and you've shared your story in the New York Times and elsewhere. And I wonder whether that legacy of fighting AIDS, fighting stigma and discrimination, made you say, I need to be public about this. Did that affect you in any way?
Well, I definitely was influenced by the fact that I'm part of the AIDS movement. First of all, I'd never been seriously ill in my whole life. It was a real shock that for the first time a virus got me and not the other way around. So I thought maybe in my try to keep some humor, and I said the virus got me now. It's the revenge of the virus. And it's particularly the experience of the aftermath of the acute episode when I was in the hospital, and I got over that thanks to oxygen and so on. And that, that was something that I thought would happen. And although I was very scared to end up in intensive care and die. But what I was not prepared for is like months of recovery and of complications. I had a chronic lung condition, so it, due to the inflammatory response of the body, not directly the virus. And it's only then that I developed shortness of breath. ironically. Um, and I'm still 3.5 months later. I'm still not 100%. I mean, I'm much, much better. I resumed working. I go jog in the morning and so on. However, for those who know me, you know that I'm kind of a night owl and stay up very late. But today, I go to bed at 9 or 10 and I'm really tired. So it's really a virus that penetrates into every single cell of your body. And it's then when I got this chronic condition that and when I was contacted by two journalists independently, a Flemish one, because they want to highlight, how important COVID is in Belgium, where I'm quite well known, and then Donald McNeil from the New York Times. First, I said, why would I do this? I'd like to talk about what to do about the epidemic, not about myself, and who on earth would be interested in my story. But then I thought two things. One, as you mentioned, I'm from the AIDS movement, and the personal stories and the involvement of people living and affected by the condition is an essential part of how we think and how we act. And then secondly, also, I wanted to show that COVID-19 is more than a bit of a flu or a serious flu, or 1% of people, that's usually said at the same time, die. And in any case, they're over 70 and they have underlying conditions. If we were not valuable citizens, and it's kind of what I got really upset about that, because it's, it's a eugenics,
Yes.
It's a eugenic type of discourse. And that's what's happening also in the homes for the elderly, for care homes where people have been dying massively. So that's why I also came out and showing that there's a lot in between a bit of a flu and dying in intensive care or just on your own. And that's, I think, what we will be facing with also with hundreds of thousands, if not millions of people with chronic conditions, sequelae, and so on. And we are not prepared for that. But it's really the AIDS experience. And, the fact that, and I don't know about the US, but in the UK, it's never about people. It is, preserving the NHS. It is, flattening the curve. It's ministers giving lectures about, R0, the reproductive rate number, and so on. And then, as an afterthought, we're saving people. I said, no, it's about people. And I think we have a credibility problem. If the only official communication is about statistics, saving a system, the NHS, and I'm a big fan, don't misunderstand me, and and I benefited from it, all for free for our American listeners and viewers, being in the hospital and with sophisticated care afterwards and PET scans and just name it, up to now has not cost me 1 penny, 1 cent, because that's the National Health Service. But it is about people, and in order to have trust in what the government says, in order to comply with the pretty unpleasant type of social measures, we need to understand it's about ourselves, about everybody. It could happen to me.
And in the US, we don't have the NHS, more's the pity, as you say, but we've been protecting the economy insofar as we've been protecting anything at all. But one of the things that I think your experience is showing us is the need for us to understand the long-term effects of COVID. And we've had this sense of, okay, people are in intensive care, they are intubated, they survive. That's it, it's finished. But we're beginning to understand that the investment in health that we need for people who have been infected with COVID-19 is actually going to extend much further. And I guess that's part of us also having to deal with an infection that we know still very little about.
Yeah, absolutely. I mean, it's new. When I went for my second time to the hospital for dealing with this chronic lung condition. The physicians were trying to figure out what is it, how to treat it, and so on. And now the experience is cumulative. We tend to forget that there was a world before COVID, but if you start counting, let's say on the 1st of January, more or less, December, we've known this for 6 months. That's all, and the experience, the clinical experience, is still very limited. But it's really accumulating. It also, very clear now that it's not because this is a respiratory virus that it's only a respiratory illness.
Yes.
That it only affects your lungs. I mean, I had atrial fibrillation. People have cardiovascular problems, kidney problems. Your brain is affected. It's everywhere. Your skin. So that is going to put an extra burden on the system. And in addition, let's not forget that because of COVID-19, many people with other conditions, health conditions, from maybe acute ones like stroke or, heart infarct, myocardial infarct, or, needing treatment for HIV, they're also suffering. So the cost in terms of lives is not only the people who die from COVID directly, but all the others. And we haven't made that really, we haven't added all that up yet. So, and that's typical for epidemics. When you look at also at the economic cost, there are the cost of dealing with, in this case, the COVID pandemic, but also all the effects, people losing their jobs,
yes.
The economy, and we need to put that in an equation. So our challenge is to make sure that we bring this epidemic under sufficient control so that the economy can run, and that otherwise we're all going to be, drowned in poverty.
We're talking, particularly in the UK and the US, of the sort of political failure to respond to COVID. I wanted to get your thoughts on perhaps an argument that might suggest that there's been a failure of public health to take the political sting out of the response to COVID. I mean, here in the United States, who would have imagined that wearing a face mask would become such a politically explosive issue? Do you think that we in the public health movement could have done things differently? And particularly when, and you sort of referred to it, when we have to tell the public, we don't know the answer to this question, you're going to have to bear with us. Are there things we could have done differently?
Well, with the benefit of hindsight, and I think that's very important, and to be fair also, it's clear that we should have done things differently. But one of the biggest challenges for this epidemic is that it's new. In other words, the level of uncertainty is enormous. Although I would say it's not to that extent that we don't know what to do. One of the very important elements when you see there are good stories in this also. There's a lot of good news. Plenty of countries have succeeded in bringing down the number of new infections to very low levels. In Europe, take Germany or take Denmark. They acted very early on. They introduced testing and contact tracing on a large scale very early on. And, they have been quite successful. The same thing is true in some Asian countries, particularly those with experience of SARS. Take Hong Kong. It's so densely populated, and they've hardly had any deaths. You would expect that this is an ideal environment for an explosive epidemic, and yet it has not happened. But you go there, everybody wears a face mask. Same thing is true in Singapore, although then they had the migrant workers in the dormitories. Japan, Taiwan, South Korea. So it shows that it can be done, but we were too slow. That's for sure. In the UK and in the US, still too slow, and depends on the state. The fact that I think the public health officials, it reminded me of the early days of AIDS, and when there was antiretroviral therapy, and that people said, no, we can't, offer that in developing countries because the health system doesn't work. we said, okay, but we'll do it, we need to save lives. So, and here, what I heard is that, the capacity is not there for contact and trace. We should have recruited the people. There are so many unemployed people now anyway. Put it in place. And also, I would say, in the scientific community, also problematic, I would say, where sometimes we ask for the ultimate evidence, preferably produced locally in the UK by British investigators, published in British medical journals, and then we accept it. And there's still no consensus on face masks in Britain, and it's still not compulsory. But for me, the evidence is enough. There is enough evidence. It's not coming from randomized controlled trials on a massive scale. But if we have to wait for them, how many people will die?
Yeah.
So we have this kind of the best as being the enemy of the good, but ultimately the decisions can only be political.
Yeah.
That's something that we have to understand. And it's also clear that scientists need to make sure that they understand what their role is. Our role is advice, making sense of what, is the evidence. But scientists love to, argue with each other. And that's not something that in times of crisis you can do. And one of the problems in the UK has been that there are many chefs. There's a lot of it is the impression it gives, and I'm not in the inner circle in number 10 or I'm not on stage or so on, but it's kind of managing by committee. And one of the points I've made is in times of crisis, you need a general, someone who's in charge with authority across the government, brings in, local authorities for a local response, because that's what's needed. Look at now, we have Leicester, where there is an outbreak, and working with the private sector, with the civil society groups, and not just a, government bureaucracy that has clearly been unable to have rapid, flexible procurement or organized testing. These are issues that could have been resolved. It's not rocket science. It's about coordination, logistics, communication.
It's something you've said in the past. It's the management of an epidemic, of a pandemic. It's not sexy. It's not someone in a white coat or someone out in the front, but it's the logistics. It's the basic day-to-day getting of it done. And I mean, here in the US, you sort of sense a carving out over the last decade or so of investments in public health, and a lack of central leadership. But something is about to change when the governor of Texas requires that everybody has to wear a mask. But one of the other things about you, Peter, is that you are, I guess, I would call you a pragmatic optimist. How do you see the world adapting to COVID in the coming years? I guess we're all going to be wearing masks much more frequently. But are there things that you see that we will just sort of incorporate this into the way that we live?
Definitely, and we have no choice but to do it. But before to that, I think also the fact that in many, many countries, investment in public health preparedness has actually gone down over time. All the money went to care and hospitals and all that. And the irony is that there are these rankings of countries, whether they were ready for facing an epidemic, that were published. And the irony is that the countries that came on top of it, the US and the UK, have kind of some of the worst performance. So it illustrates that it's not about just ticking off boxes. We don't have the systems in place that are ready, as countries like in the East, in East Asia have.
Yeah.
But I think it's not too late for two reasons. One, we're only at the beginning of this epidemic, and I think that's a sobering, bad news. But it's only the beginning. So there's time to do better and to learn from our successes and failures, because both have been there in every country. And also there will be other epidemics too.
Yeah.
A nightmare scenario would be that this winter in the Northern Hemisphere, we are having a double epidemic of, COVID-19 and some new variant of influenza virus. That could happen.
Yeah.
I'm not saying it will happen, or in 2 years' time. So it's at the beginning, and as societies, we need to start thinking about living with COVID, just as we are now in societies living with HIV, where we moved from an epidemic, acute epidemic, slower in the case of HIV because incubation time is slower and so on, it's longer. And I think for COVID, we'll have to go into the same, direction in terms of how we deal with it and how we accept it. And it's about the risk management and it's about harm reduction.
Yeah.
And it means that we will need a collective behavior change. It's very interesting to think, the first time I went to Japan many years ago, and I saw people with a face mask. And I thought, oh, there's people there a bit paranoid, they're scared of getting infected. I had not understood, after I made a comment on that this is actually about protecting others. It is an altruistic, gesture. And anybody in several countries in Asia, if you have even a slightest common cold, you protect the other community. And that goes back in the case of Japan to the Spanish flu, just 100 years ago. And I hope that we will adopt something similar now all over the world.
Yeah.
Some kind of social distancing. I mean, I come from a culture where we kiss and hug and shake hands all the time in Belgium. But probably that's not something that's very smart in when viruses are flying around.
Well, I suppose that's the advantage of my tribe is that the last thing you would do is hug and kiss your family members.
Yeah. Except when you're drunk.
You're drunk.
Yes, but but I think in Japan, in India, in Thailand, and so on, the fact that there is the way people greet each other. Who knows where that comes from? It could come from maybe some old epidemic. Who knows?
Yeah.
But I totally agree with you. We have to start adopting change our behavior collectively. Long way, face masks, even if they're not 100%. If everybody uses it, I think the population effect and impact is going to be enormous. And this will also be very important to determine whether the outbreaks that are going to happen as whatever we call it, second wave, third wave, and so on, will remain limited to a particular neighborhood or city or company or school or university. That will depend on whether we have a collective type of safer behavior, plus a system in place that can rapidly detect whether there's a problem, where people are infected, and that means testing and good information systems at the local level, and then act and quarantine without hesitation. And we may go back to that kind of pattern for years.
Yeah. But I think there's something very important that you've said there, that the wearing of the mask is not to protect yourself, it is to protect others. And I think that's a message that we've done a really bad job actually here in the United States of communicating. And I've seen people absolutely obsessed with Purell and hand washing, but the concept of the mask as a sign of respect for other people is something that really hasn't taken off. One of the other things, Peter, is we're just going to, the argument would be we're just going to hunker down until there's a vaccine. And there's been huge enthusiasm and huge investment in vaccines. But sort of here's the deal from my perspective. We've not done a good job of producing vaccines very rapidly. Our science doesn't tend to allow us to do that. And secondly, if I'm right, we haven't actually succeeded in developing a vaccine against a coronavirus. So are we being overly optimistic that come the middle of the next year, everything will be fine once we're all vaccinated?
I'm spending a lot of my time now on helping to support the development of vaccines, for example, through CEPI, the Coalition for Epidemic Preparedness Innovation, and also as a special advisor to Dr. Ursula von der Leyen. She's the president of the European Commission and really has played a leadership role in mobilizing money for development of vaccines, manufacturing, and for equitable access. So I think a vaccine is going to be absolutely essential to bring down this epidemic to levels that are manageable in societies. But I think that the promises that have been made may be over-optimistic, and we may have a big problem of managing expectations here. First of all, we need a vaccine that works, that protects. But what's absent from the discussion often is that, will it protect to transmission? In other words, if I'm vaccinated, I can't become infected, or is it going to protect me from developing a serious illness and dying from it, which would be absolutely very, very important. But if it's only the latter, then that means that the virus will continue to spread, so we don't know what will happen. So it's unlikely that certainly the first generation of vaccines that will be developed will offer 100% protection from either infection or disease. So that's the first question. And so we need to demonstrate that this vaccine protects, and that takes time.
Yeah,
that takes time. You need to test it in randomized controlled trials in populations where there is still active virus transmission of the coronavirus. It takes some time, and it's a moving target also, because in many countries now the incidence is too low to test it out. But anyway, we have to show it's protective. Secondly, very important, equally important, it must be absolutely safe.
Yes.
Because with vaccines, we're injecting biological materials in healthy people. And in this case, we're talking about billions of people, not millions, but billions. Maybe 4 or 5 billion people on Earth will need this, or could even be more. And that means that you can't afford to not be absolutely certain that this is safe. And that requires some extensive experience with these vaccines in various populations, from younger to the elderly. And by the way, many vaccines don't work that well in the elderly and in someone over 70 or 80. And these are exactly the groups in society, the age groups we want to protect, in addition to healthcare workers and so on. So it has to be absolutely safe. And one theoretical possibility is that vaccines could even enhance infection. There are some precedents for that, just as we know for some dengue vaccine. I'm not saying it will happen, but we need to go through that. And then the third block, let's assume that all this works out very well, that there's no problem, which I would be surprised, because the average rate of success of development of a vaccine from the first experiments to bring it to the market is way below 10%.
Yeah.
And it usually 8 to 10 years. I'm not saying it can't be going faster, and I think it can be. And we need to do everything we can, including, the collaboration of the regulatory bodies like FDA and the European Medicines Agency, and they're on board. But we need to be realistic. So let's assume it all goes well, and we are probably the end of this year in the best possible case, although some people have promised hundreds of millions of vaccines by October. Who knows? I think it'll rather be 21. then we need to manufacture these billions of vaccines. Again, never been tried before. It doesn't mean it can't be done, and I'm sure it will be done, but that's not for a university or so. That's not an academic problem. That's engineering. It's finding billions of the small glass vials to put the vaccines in, the injection needles, and so on and so on. And then lastly, let's assume that all that is fine. Then we need to make sure that it can be distributed, that it's affordable. And one of the things I like very much of the initiative that the EU, together with WHO and others like CEPI and Gates and the Wellcome Trust and countries have really launched, is the insistence not only to produce a vaccine, to discover it, to produce and manufacture it, but to ensure equitable access. And because there's a big danger of vaccine nationalism. Just as we see now the fact that the US government has basically bought up most of remdesivir, of Gilead's remdesivir, meaning that patients in other countries, are not going to benefit. That's going to cost lives. Can't we have some, better understanding and more equitable access and distribution? It's going to be one of the big political issues of the next decade.
It's really interesting that the Europeans, and I suppose we now have to exclude the United Kingdom from that, God help us, but that the Europeans coming to the support of WHO and CEPI, sort of, I guess, primarily based in Oslo, Norway, are really at the forefront of demonstrating leadership and the need for solidarity and the need for investment. And the other voice that obviously very optimistic about vaccines, but someone you mentored and then someone who went on to mentor me, Dr. Paul Stoffels from J&J, the need that we're going to have to vaccinate billions of people and really to start thinking right now about what it means to manufacture, to scale up, but yes, to make sure that this is accessible and available equitably. It's going to be, it's not the magic bullet that perhaps the America First people think we're going to have. It's going to require a lot of work.
Yeah, I agree. I mean, it's not a magic bullet. We'll need, like the term we use in HIV, combination prevention. So even if there's a vaccine, and I really hope that it'll be there, like say a year from now, then we will still have to continue to wear masks, face masks, to have other measures, because it's highly unlikely that it will just stop this epidemic magically. And secondly, the debate also has started, who comes first?
Yes.
Who will benefit first? Because let's assume that there are 100 million or 200 million or 300 million doses, but not billions of doses immediately. So we'll need to make some very tough choices. The logic ones being to protect all those who are caring, healthcare workers, people who work in care homes for the elderly, maybe the most vulnerable, et cetera, et cetera. So that's something that each country has to decide, and where we need agreements. But sometimes I feel that it's another case of medical hubris to promise that we will fix this epidemic with this technology. Also, I think we need to not neglect research into therapeutics in the treatment. And it could well be that, antiviral treatment becomes available and is proven to work a bit faster, remdesivir plus, let's say, and more effective. But that also can be used as prophylaxis in a preventive way. You could imagine that all the contacts of someone with COVID-19 can be given an antiviral drug or monoclonal antibodies that are protective. So we'll need multiple approaches to bring this under control.
Yeah, and and then that sort of gets to that balance of making sure the data is proves the case, but isn't the kind of gold standard that US or London-based magazines or journals want. You remember that you and I were talking just before all this hit, and I was in Cambodia meeting with manufacturers and distributors of HIV medicines and persuading them, and I think largely successfully the group of us were, to prevent them from sending all of these unproven antiretrovirals, yes, including D4T, over to China, and that they might be used as ARVs, as prophylaxis against COVID. So there's that balance between needing to move quickly, but moving on evidence, and that sort of hit me so forcefully then and now, and I guess that brings us, Peter. And I don't want to take up too much more of your time, but really to HIV, which is the epidemic that has driven your life and has driven my life, and. Like SARS-CoV-2, HIV is a zoonotic infection. It crossed over the animal-human barrier sometime in the 1920s, and here we are with a range of pandemics, and I'm hearing some very conflicting things about HIV. The first is that this is an opportunity for us to reframe the debate about HIV. We're in a world of needing to build pandemics literacy, pandemics preparation, so we can incorporate HIV into the broader pandemics response. And then you also see a sense of almost desperation, which I confess is sort of almost where I am, where you see a huge shift of resources away from fighting HIV and into the emergency need to deal with COVID-19. And, it's the irony of saying this, HIV just isn't sexy anymore. It's a disease that you can get very easily, but symptoms don't appear for many years. The fatigue that goes with needing to build a long-term response to it is something that you have to fight day in and day out. But what's your sense? And I know you're going to be speaking at the virtual AIDS 2020 about the AIDS response, and I don't want to anticipate that. But what's your sense of what we need to do?
Well, first of all, Ben, the COVID-19 has a direct impact, a negative impact on the lives of many people living with HIV because of the interruption of services that is not only affecting people with HIV, but with diabetes, just name it. According to UNAIDS, one estimate, it could lead to an extra 500,000 deaths because of lack of access to antiretrovirals. And so that's an immediate impact that is not specific for HIV, but we need to take into account. Same thing for people with tuberculosis and so on. But I think that the COVID-19 comes at a time when the AIDS movement was already in a crisis, and where there's already a lot of of complacency, denial, so this is it's high time to probably rejuvenate, I would say, not only the response but the narrative to start with, in a world living with COVID and a world living with HIV. What I find very disappointing is that from the UN to civil society groups and so on, and professionals, that you hardly hear any voice about AIDS. This whole groups, all the people have just only talk about COVID-19. And of course, we need to bring COVID-19 under control also in order to be able to, to deal with HIV. And certainly, when we see 2020, this year, is one of an interim target timeline for the UN and UNAIDS targets to end the epidemic. We are not there by any means. It's and that we can't blame on COVID-19. that was already in the works before. So it's really a mixture of limiting the damage, of the acute damage, but also I would say a double incentive to rethink the strategy, the strategy which was entirely targeted focused on targeting on 1990 and treatment and so on. And that's clearly not going to make it. We would have made it quite a while ago if that would work. And we need to shift more to prevention, but also connect it with, with issues around COVID-19 and others. I think an opportunity is the new UNAIDS strategy, which will, sorry.
That's all right. Life happens.
Yeah, it's from the US. Who knows? Someone is already listening. No. So just, I think we have an opportunity with the new UNAIDS strategy that's in development. But if that is just more of the same, I'm really concerned that we will see a reversal of the hard-won gains of the AIDS response. And we shouldn't forget that millions of lives are hanging in the balance. COVID-19 is a very serious epidemic, and I think the official figures are a total underestimate. Certainly, when we think of 10 million people infected in the UK, having access to testing until recently was extremely difficult. I had to go privately. That's the only time I had not had to go to the NHS to have a test. It's probably well under 1 in 10 people with the infection are being tested and are in the official statistics. So we probably easily 50 to maybe 100 million people who are infected. However, when you look at deaths, let's not forget that there are 600, 700,000 deaths a year from HIV every single year. Cumulatively, we're close to 35 million. So that's up to now, since the Spanish flu, the biggest epidemic of our times, and we should also say that loud and clear.
Yeah, and I'm seeing, I mean, already some of the pre-conferences for the virtual AIDS 2020, where some of the more draconian methods for making sure people don't meet and don't socialize are being used by police and authorities to prevent key populations from doing their work and interacting, and that's something that we're going to have to watch. I suppose it gives a very focused emphasis on a rights-based and evidence-based response to HIV, when perhaps we were losing some more of that focus in previous years. But
yeah, that's a good point. But I also think always there is an opportunity. And that opportunity is that you don't have to explain to most people now why dealing with infectious diseases, why global health, why epidemics, why that's important, and why we should invest in that, and and invest in preparedness and in community responses and so on. So I hope that that's something that will not only lead to defeating the COVID-19 pandemic, but also helping to bring HIV under control. But we need to learn lessons from both of us. And what's common, I think, not only that it's virus, but is risk reduction, harm reduction, in a way that's more realistic than claiming the end is in sight, because the end is not in sight for either.
Yeah. Well, there you go again, being the pragmatic optimist and sort of giving this a sense of what we need to do. Now, Peter, as we wrap up, you've been through the wars, as we would say. How have you kept sane? How have you maintained your sense of optimism and enthusiasm?
Well, I think that the alternative is much worse. So what's the point? And I mean, we should never accept that the unacceptable, that people die from treatable conditions or preventable conditions. And for me, that's such a given. It's sometimes hard as an individual to, from when I was in charge of UNAIDS and the personal attacks you get and so on, and but never lose sight of that, of a long-term view and of why we're doing this, and that we all need together to work together to to make a difference and to save lives. It's for me, it's as simple as that.
Well, Peter, thank you so much for coming onto the podcast again. It's really terrific to have you here. It's really also wonderful to see. I mean, I realize there's much more to go, but to see how much of a recovery you've made, and that's just wonderful. Keep up the terrific work, and lots of love from your family in California.
Thanks so much, and good to see you.
Well, that's it for this episode. Thank you so much for joining us. Thanks to Professor Peter Piot. Thanks also to Erica Spera, our producer and director from Newsdoc Media. Thanks also to Brian Ragas, our production manager. As always, you can contact us at Facebook and YouTube at Shot Arm Podcast, and you can find this and other episodes wherever you get your podcasts. Now, have a great week and a safe week. And of course, don't forget to keep wearing your masks. Thank you.